essentially what I want to do today is to really review point of care ultrasound in sort of an all-encompassing way, and sort of how we approach using it, especially in the critical care setting when patients are critically ill and coming in with shock. So I sort of just wanted to walk through the different types of shock and how we can sort of differentiate between those utilizing ultrasound. Oops, hold on 1 second. Perfect. All right, everyone can see the slides okay, right? So, like all of my other talks, I'm trying to make this as interactive as possible. So feel free to speak up either through chat or unmute yourself, whatever, and we'll get started. We should finish ahead of time, hopefully. But, just a quick definition of shock. So basically, with shock, we're dealing with an acute circulatory failure, right, associated with inadequate oxygen utilization by the cells. So in these instances, circulation is unable to meet the oxygen demands of the tissue. And so you're getting a mismatch between oxygen delivery and oxygen consumption. So, especially in the critical care ICU setting, it's a very common diagnosis. Up to a third of patients in the ICU have shock of some sort. And why do we care? Well, it's associated with a very high mortality. So, and it's very important that we recognize these patients early, and point of care ultrasound helps us do that. So in terms of shock, there are really 4 major types that you guys should be differentiating between. Keep in mind that patients often have undifferentiated shock. They have 2 different types of shock going on. So it's not end all be all, but for the sake of the talk, we really divided it into obstructive, hypovolemic, distributive, and cardiogenic. And I'm really going to go through examples of each using ultrasound. So starting off in general, so this is very well described in the emergency room literature. So there's a specific exam called the RUSH exam, and it stands for Rapid Ultrasound for Shock and Hypotension. And really what it is, it's a 3-step protocol where you look at the heart, you look at the volume status, and you look at the arteries and veins themselves. So if you start off by evaluating the pump, so we're just doing a general cardiac exam with the ultrasound. So are we looking for pericardial effusion? We're looking at LV function. We're looking at the size of the right ventricle. And then you want to go over to evaluating the tank. And so really that's going to be your main views to establish or figure out what the intravascular volume status is. So you're going to perform a lung ultrasound, right? Hopefully there's going to be lung sliding, right? But there may be absence of lung sliding. You want to evaluate whether there are B lines. And then you want to perform a generalized FAST exam, which we'll talk about a little bit later, but that's going to be important for any patients who come in hypovolemic if there's concern for hemorrhage. And then lastly, you want to evaluate the pipes. So that's going to be your main time to evaluate the arteries and veins. I would say for the most part in the critical care IM realm of things, we don't look at the aorta in too much depth. That's mainly isolated to the ED people, but we certainly can look for a DVT, and that's important if we're worried about PE. And so this is just showing 3 different types of your main cardiac views here, your views of the lung and your abdominal exam, and then your views for the aorta and the DVT study. And so this is just showing, if you do the RUSH protocol, what you may find and how that helps differentiate the type of shock, right? So if we're looking at the hearts, right, and we're seeing that it's hyperdynamic, the chamber size is small, that might be seen in a patient with hypovolemic shock or more of a distributive shock, whereas in the patient with cardiogenic shock, the heart's not going to be pumping well. So you'll see more of like a dilated heart or a reduced function here. And then obstructive shock is going to be your main time where you look for, if you're looking at the heart, cardiac tamponade, signs of RV strain, a clot in transit, if you're looking for a massive PE. And then in terms of the tank, so the intravascular volume status, the main thing to look at to help differentiate between the types of shock would be the IVC. But then certainly if the patient has free fluid in the abdomen, that makes you worried about hemorrhagic shock, right? If the patient has an absence of lung sliding, makes you worry about a pneumothorax. And then for the pipes, the arteries and veins, the main thing you're going to be looking for is, aneurysm of the aorta, dissection of the aorta, or if the presence of DVTs. So it's just a quick protocol. I think in the medical ward, you probably won't necessarily need to use this, but it's just something, a way of evaluating the patients in a holistic manner. So starting with the specific types of shock. So the first one we'll start with is obstructive shock. And so I've included some examples of the most common types that you'll encounter, in the medicine wards or in the ICU setting. So The things we most worry about would be cardiac tamponade, massive pulmonary embolism. And with a massive PE, right, the lung exam should be normal. So you get a normal A-line lung pattern with lung sliding. And then the key findings would be an enlarged right heart with signs of RV dysfunction. We talked about McConnell sign during the last talk. The other type of obstructive shock to worry about, especially in vented patients or patients who've had procedures to the pleura, is a tension pneumothorax, right? And that's basically diagnosed with absence of lung sliding or more specifically lung point. Can you guys think of any other differentials for causes of obstructive shock? Can't see the chat for some reason, so I don't know if there's a. Oh wait, hold on. Let me see.
No, I can let you know if anyone.
Okay.
Yep.
Thank you.
No problem.
So, any other causes of obstructive shock that you guys can think of?
I guess it's a difficult one. No one is attempting.
So I would say the main thing, the main thing to worry about is something like constricted pericarditis, which is kind of an overlap of something like a cardiac tamponade or pericardial effusion, right? The other thing would be, so, you know, aortic dissection could behave, depends on the type of dissection. Certainly if you get blood that forms around the heart or in the pericardium because of the dissection, then that could definitely cause an obstructive shock type picture. The main things to also worry about would be a patient with malignancy. So if they have some type of vena cava obstruction, whether it's from a tumor or something else. And then the other common thing is, especially patients with like severe asthma who are ventilated, you can get auto peeping, right? So if the intrathoracic pressure builds up higher and higher and higher, that pushes pressure on the heart as well. So those are all things to consider. But in terms of obstructive shock, using ultrasound is going to be immensely important, right? Because if you're worried about tamponade or PE or tension pneumo, the treatment is extremely different depending on the actual etiology. So it's important to use POCUS to rapidly diagnose these things. So in terms of starting off with evaluating a pericardial effusion, so this is the best view to pick this out would be using the subxiphoid or subcostal view. Right, so this is going to be right below the sternum, looking up towards the heart. And this is going to be a common entry point for pericardiocentesis if that's something that's indicated. But keep in mind, usually you can see pericardial effusions in all cardiac views. And if in terms of quantifying the effusion, so, you know, you want to make sure when you're measuring it that it's perpendicular to the long axis of the heart. You want to avoid oblique angles. So meaning that, you know, if you are not perpendicular, you might overestimate the size. And in terms of size cutoffs, so we quantify pericardial effusions as either trivial, small, moderate, or large. And this is how we size them up based on the diameter. So trivial would only be present in systole, and it might actually even be hard to find sort of in the bedside scenario, whereas small pericardial effusions are going to be less than 5 to 10 millimeters. Moderate gets to 10 to 20 millimeters, and then large will be greater than 2 centimeters. There's been in some areas of the literature, they have very large, as greater than 2.5 centimeters, which you'll probably rarely see, but it does happen, especially in patients with chronic effusions. So I just wanted to include some examples of what different pericardial effusions look like. And so this is, what view are we looking at here?
Guys, what's the view? You know, you said it last time, I remember. They're saying parasternal long.
Perfect. Yep. So I agree. It's parasternal long. And then I just want to point out, can everyone see my little finger thing here?
Yep.
So this is the small pericardial effusion, and you can tell it's a pericardial effusion, right? Because it's above the descending aorta, which is right here, and it's right below the left ventricle, and it tracks all the way around. And it's small because it's definitely less than 5 to 10 millimeters. It's maybe a millimeter or so. So this would be something that classifies as a small pericardial effusion. Probably not clinically relevant, but it's something that would be important to note. right, so this is another example. What do you guys think here? What review are we looking at? Yep, perfect. Yep, so this is the parasternal short axis, right? So you have your left ventricle right here in the center, looks nice and circular. You have your right ventricle up here. And then you can see around the ventricles, there's a rim of dark, which is fluid, which is going to be a small pericardial effusion as well. So now we're getting into effusions that are a little bit more noticeable. Can you guys tell me what you are looking at here? Yep, exactly. Yep, apical four chamber, right? And so you have your left ventricle on this side here, right ventricle here. You can't really make out the left atrium and right atrium too well. You have to sort of imagine that they're down here. And then you want to just pay attention to this rim of black fluid around the heart. So this is going to be a moderate pericardial effusion. And it's probably right around 1 centimeter, I would say. You know, these dots usually denote a centimeter, and I think it's probably around 1 centimeter. You do want to measure it during end diastole, which is when the ventricles are filled up the most, because that's going to give you the smallest measurements. You can see at the end, like if I pause right here, it's about 1 centimeter. Whereas when the heart contracts, it looks a little bit bigger. All right, so this is another example of a moderate pericardial effusion where you can really appreciate the effusion down here, right? And so what view is this, guys? There's going to be another parasternal short axis view, right? Yeah, perfect. So you have your left ventricle here and right ventricle up here, and then your rim of fluid surrounding the heart. All right, now we're getting into a little bit more worrisome findings here, which we'll talk about a little bit later, but I just want to point out for this view, so this is going to be actually a subcostal view. It's not the greatest image quality, but you have your right ventricle here, left ventricle down here. Right atrium is here, and left atrium is going to be somewhere here, and you have a very large pericardial effusion. It's probably closer to 2 centimeters now. So whenever, you know, with something like this, especially when you see the ventricle moving inward at inappropriate times, this is when I start getting worried that we may have something like cardiac tamponade. So how do we evaluate patients with cardiac tamponade? It's really through a stepwise approach using point of care ultrasound. So first, obviously, you want to ultrasound the heart and evaluate the size of the effusion. The next thing you want to do is you want to look at the IBC, right? So in a patient with obstructive shock, there should be a backflow of blood into the IBC. So in all patients with cardiac tamponade, the IBC should be plump. So if you're worried about tamponade and you see an IBC that's collapsible or very small, then that rules out tamponade, okay? The next thing you want to look at is pay more attention to the right-sided heart chambers. So you can pay attention to the right atrium. If it collapsed by more than a third, then tamponade is likely. But the more specific finding would be right ventricular diastolic collapse. So when the right ventricle is supposed to be filling, is it collapsing inappropriately? And whenever you're in doubt with, you think of, okay, the patient has cardiac tamponade and you don't know what to do in the interim, you know, obviously you can start by giving fluids and then call for help right away, whether it's cardiology, critical care, or rapid response. And keep in mind that the size of effusion, you know, may not necessarily rule in or out tamponade. So a small effusion can still lead to tamponade. It really depends on the rate of fluid accumulation. So if you have a patient who just underwent cardiothoracic surgery, right, a rapid fluid accumulation will provide less time for the heart to compensate. So in those cases, the effusion size may be small, whereas a patient who maybe has a malignant pericardial effusion has had months to sort of compensate as the effusion's gotten worse and worse. And so their effusion might be very large and still no signs of tamponade. So I just wanted to give you guys a few different examples of tamponade where you guys, sorry, where you guys can just look at some examples of things that were classified as tamponade. So here you have, it's kind of a parasternal long axis view, I would say. So this is going to be your right ventricle outflow tract here, your left ventricle here, then you have your mitral valve, and then your aortic valve here. And then I want you to pay attention to the large ring of fluid, the large pericardial effusion. And then you really want to look at if you're seeing a large effusion, you want to pay attention to the right ventricle and what it does during diastole. So how do we know when it's diastole? So if it's collapsing when the mitral valve is opening, that's abnormal. So the mitral valve is opening, the blood's flowing into the left ventricle, so the left ventricle is filling here. So if the right ventricle is collapsing when the left ventricle is filling, that's abnormal, and that's indicative or concerning for obstructive shock and tamponade. And so you can see it bouncing inward inappropriately when the mitral valve is opening up. Does that make sense? This is another example, but we're using a different patient and a different view. So this is going to be a parasternal short axis view. And in this one, you have the left ventricle here, right? And then you can kind of make out the right ventricle, and it's kind of hard to see actually on the screen here, but there's an inward collapse with the opening of the mitral valve as well, and there's a large pericardial effusion. So this would be another patient who has tamponade. This clip, they kind of slowed it down at some point to make it maybe a little bit easier to see. So you can actually see as the anterior leaflet of the mitral valve is opening up, the right ventricle free wall is going inward. So that's abnormal, and that's indicative of tamponade. There's a large pericardial effusion above it, and then maybe to a lesser degree below it, but it's large enough to cause the tamponade. So you can actually use M mode if you're not sure, right? If the RV is collapsing inward or outward. And so you want to correlate the free wall of the right ventricle with the opening of the anterior leaflet of the mitral valve. And so if they're moving towards each other, that's inappropriate, right? So the right ventricle should be opening up the same time as the mitral valve is opening, or sorry, the right ventricle wall should be expanding while the mitral valve is opening. So the fact that the wall is moving inward as the anterior leaflet's moving to the septum, that's abnormal, and that's indicative of tamponade. So if you're not sure, you can always add N mode to look at it over time. It's more of an advanced echo move, but it's something that can be done at the bedside readily and give you a little bit more evidence and assurance that what you're seeing is abnormal. And so, like I said, you always, if you're worried about tamponade, you always want to look at the IVC and verify what the IVC looks like. For us to be worried about obstructive shock and tamponade in general, the IVC should be plump and grossly non-collapsible. So in this case, you want to, this is, I would say, probably from somewhere from the ED literature, because it's flipped. The heart's over here, the IVC is here, the liver's here. And then you can see the hepatic vein draining into the IVC. And you always want to measure it about 2 to 3 centimeters from the entry point towards the right atrium. So it probably, if I were to measure, it would be around here. And it's about 2 centimeters. So it's pretty plump, not really that collapsible. So that would be consistent with a tamponade picture if we're seeing signs of tamponade on the other views. I think I have a couple more views just to highlight that you can see tamponade really in all of your point of care ultrasound views. So again, this is going to be your apical 4-chamber view. So you have your left ventricle here, your right ventricle here, right atrium down here, and then your left atrium here. You have a large pericardial effusion. You can see the rim around over here and here. And as this mitral valve is opening up, you can kind of make out that the right ventricle free wall is moving inward, again, indicative and diagnostic of tamponade physiology. And you can also see that the right atrial wall is collapsing as well. Again, this is maybe a little bit more sensitive, but less specific. If you see the right ventricle diastolic collapse, that's more specific of tamponade. What are we seeing here? What do you guys think? What view are we looking at here?
Jonas is saying subcostal.
Yep, subcostal. And then what do we see here? Oops, sorry. Yeah, excellent. So yeah, this is basically you see black here, which is part of the effusion, right? But within the black, there's something else, right? That's a little bit like a lighter shade of gray, right? And so that's pretty diagnostic of hemopericardium. So this is blood in the pericardial space. So I think in this case, the patient had a recent cardiac surgery and became acutely unstable in the CCU, and then they did the echo, and this is what they found. So yeah, this is definitely would be very worrisome and would need some surgical, would be a surgical emergency depending on the clinical scenario. But yeah, so that's what hemopericardium looks like. And there is signs of tamponade as well in this view as well. You can see the right ventricle moving inward. So obviously obstructive shock, I spent a lot of time talking about tamponade, but it's not the only cause of obstructive shock, right? So certainly, especially in myself as a pulmonary and critical care physician, that one of the things we most worry about whenever we get a consult is, could it be a massive pulmonary embolism? So I just want to use this clip again to highlight what we call McConnell sign, right? So again, you get with McConnell sign, it's indicative of right ventricle strain and right ventricle dysfunction. So basically you get a relative hypokinesis of the free wall of the right ventricle with sparing of the right ventricle apex. So that's why the right ventricle apex looks like it's hyperkinetic, but really it's just moving normally. And if you just imagine the right ventricle apex as a trampoline and someone jumping on the trampoline, that's what you see with McConnell sign. So that would be indicative of at least right ventricle dysfunction and right ventricle strain, not necessarily pathognomonic of a PE. And then what are we seeing in this second clip on the right? I guess we can start by saying, like, what view is this? Yes, Kruti, yeah, very good. So this would be a dreaded clot in transit. So if you look, this is a 4-chamber view, right? So you have your left ventricle, left atrium, right ventricle, and then right atrium's here. And then there's like something in the center of the right atrium. It kind of looks like it's going into the tricuspid valve, but it's hard to say for sure. But this is a clot that is impending moving towards the pulmonary artery, right? So that would be very bad if the patient already had significant clot burden in the pulmonary arteries. If this were to go and occlude further, that might be an emergency. And so this would be a patient that would definitely need a PERT activation and potentially clot retrieval. But yeah, so this would be a dreaded, scary complication that you might see. Very, very unusual, but we do see it maybe a couple times a year. Then the other common cause of obstructive shock, especially in patients, we saw with COVID or other patients who have very high vent settings for a long period of time, the synchronous vent, and then become hypoxic and hypotensive. So what are we highlighting in this view on the left? Yes, excellent. You guys remembered your lung ultrasound knowledge, which is great. So yeah, there's no lung sliding on this side, right? You can see the pleura is pretty still throughout the entire cycle. That would make us worried for pneumothorax, not necessarily that diagnostic, right? There's other things that can cause an absence of lung sliding, right? Whether it's atelectasis, the patient may have had prior pleurodesis. And then what are we seeing on the right? What is this called? Yeah, so I will agree. It looks like curtain sign, but actually, this is what we call lung point, right? So you have an area where there's there's no lung sliding, right? You can see on the right, the pleura is not moving here. And then as the patient takes a breath in, there's an area of lung that does come in. So this actually represents the border of a pneumothorax, where above it in this case, because this is depending on whether they were holding the probe correctly. There's normal lung sliding with the movement of the pleura, whereas right here, there's an absence of lung sliding with no movement of the pleura. So this would be serve as your border and would indicate where we may want to put the chest tube. Obviously, you want to put it in the area where there is no lung sliding. You don't want to damage any lung that's functioning. So definitely if you see any of these, let the critical care team know. So moving on, any questions about obstructive shock? So just moving on to distributive shock, obviously the most common form of distributive shock that we'll especially see in the hospital is going to be sepsis. But there are a couple other things that can cause distributive shock, such as toxic shock syndrome, anaphylaxis. Rarely you'll get what's called neurogenic shock, and that's usually following a high spinal cord injury or in patients where there's disruption of the sympathetic nervous system. Distributive shock compared to the other shocks, other shock states is a little different because cardiac output and contractility is usually going to be preserved or even hyperdynamic. And so that'll help you differentiate distributive shock from something like cardiogenic shock. And so these are just some of the classic findings I've included for a patient with a septic shock picture. So what are we seeing on the left? What's the view here? And then what do we think of the LV function? Yep, so we have the parasternal long. And what do we think of the LV function? And how do we know? So, I mean, I definitely agree. I think this is hyperdynamic. You can kind of see the walls here. They're basically touching each other, right? The cavity is getting completely obliterated with contraction, and then the anterior leaflet is touching the septum. So all of those are signs that this patient has hyperdynamic LV function. And so then once we do our cardiac assessment, then I look at the IVC to check for volume status because the patient, is hypotensive after all. And then what do we see here? Yep. So this is basically a very small collapsed IVC. It's almost sometimes what we call it virtual IVC when it's like so small that you can barely see it. So this is definitely a patient that you were worried about or you would think might benefit from volume resuscitation. And so if we're worried about septic shock, the main thing we also have to find, right, as part of, sure the patient meets SIRS criteria, but we need to ID an actual infectious source. So what are we looking at on this clip on the left? A consolidation, right? And do we think it's a pneumonia or atelectasis, and how can we tell? Awesome. You guys are doing great. You guys are becoming POCUS experts. Yeah, so these air bronchograms are moving with inspiration, right? So, or with respiration, I should say. So if that means there's air going into at least part of the consolidation. So this is going to be more indicative of a pneumonia. And then what are we seeing on the right? So I think, it's not really fair because I don't think you guys haven't really had talks on this yet. So this is actually, it's a tricky one. And actually it's labeled, but this is actually a gallbladder right here. And so the one thing you need to pay attention to is, so you see a bright white area, which is the hyperechoic area with, it looks almost like beelines below it, or shadowing below it. And so the area, the wall, this is the gallbladder wall, and it looks a little bit irritated. It's not very smooth. And the reason why they have these beelines added and you can't really see the rest of the gallbladder is because there's actually air there when there shouldn't be. So this is an example of the emphysematous cholecystitis. So you can use ultrasound for biliary stuff, and you guys will hear about it probably later this year, I think maybe May. But I just wanted to point it out that, you can find multiple sources of infections using ultrasound, right? So you can do above the diaphragm, below the diaphragm. You can do, look at the bladder for, cystitis, and things, endocarditis, all things like that. So just going back to the IVC, so the IVC is very important to interpret for in patients that were unsure about their volume status. And they've done many studies in the literature about it over the past couple of decades using ultrasound. And IVC interpretation, the views are relatively easy to obtain. You use the subxiphoid view. But that being said, they can be challenging to correctly interpret. And so there is some inter-user variability when calculating IVC diameter and finding the IVC on ultrasound. And so in patients with presumed septic shock, it's going to be most useful for assessing fluid responsiveness. And actually the strongest evidence in the literature has historically been studied with patients who are passively ventilated. And so that means patients who are deeply sedated, paralyzed, even on mechanical ventilation with very high tidal volumes. And in those patients, if they saw a greater than 12% variation in IVC diameter, then that would be indicative of fluid responsiveness. So in the real world, we obviously don't have a lot of patients who meet that criteria. So that's why we use sort of less generalized cutoffs. And so I would say in any patients, non-passive patients, any patients that you're evaluating on the floor, we generally look for greater variation in the IVC, so at least a 25% variation. And usually when I tell residents in the ultrasound elective, I say you want to see greater than 50% variability for us to say that this patient might be responsive to fluids. And what classifies a small or collapsible IVC is generally if it's less than a centimeter, so if it's 10 millimeters or less, and then a plump or plethoric IVC is going to be greater than 2.4 centimeters. In terms of some general caveats, so the most common error would be misidentifying the IVC. So a lot of times if you only see one vessel, it's going to be the aorta. So keep that in mind when you're looking. You can tell it's the aorta because the aorta will dip deeper than the IVC. It'll go below the liver and go towards the left side of the heart, whereas the IVC will bisect the liver and go into the right atrium. The IVC has a thin wall, right? And it usually has some collapsibility, whereas the aorta will be thick-walled and pulsatile. And so if you can only find one vessel, I would just keep in mind that it's probably the aorta and the IVC is maybe small or collapsible. And you can use the M mode feature of ultrasound to measure the diameter. Just like if you're using it to measure the pericardial effusion, you want to measure it by ensuring that the IVC is perpendicular to the line used, because if you have oblique angles, it'll overestimate the diameter. And keep in mind, in spontaneously breathing patients, the IVC should collapse with inspiration. I'm sure if we all did IVC ultrasounds on all of us right now, especially some of us who are more dehydrated than others, our IVC will definitely collapse. But in patients on positive pressure ventilation, this is reversed. IVC will actually distend with inspiration. It has to do with the changes in intrathoracic pressure. And so the IVC measurement is important because it actually serves as a surrogate for estimating right atrial and central venous pressures. We obviously don't do Swan-Ganz catheters really anymore. We sometimes have CVP monitoring, but it's usually only seen in the ICU or CCU. And so depending on what you're seeing on IVC ultrasound, we'll be able to help you estimate the right atrial pressure. So if the IVC is completely small and collapsible, then the atrial and central venous pressure is very low, 0 to 5. Whereas if the IVC is very plethoric, non-collapsible, then central venous pressure, right atrial pressures might be very high. And I guess, how do we tell the aorta from the IVC? I already kind of told you guys, but what are some of the ways? I would say this is just a quick clip highlighting the differences between the IVC and the aorta. So the IVC, you're not seeing it in full view here, but the IVC is going to be here. You'll also be able to see hepatic veins drain into it. So that's another tell. And then it'll stay within the borders of the liver and go into the right atrium, whereas the aorta will quickly dip below the liver and below the IVC and down towards the left side of the heart. The aorta under normal circumstances will be a little bit bigger in diameter, thicker walled and pulsatile, which you can appreciate here. Great, guys, yeah. I should have been patient. I should have waited. All right. So this is just showing how you would calculate IVC diameter using the M mode. So if you have a good view of the IVC, and this is again flipped, the heart is here. And then the IVC is draining in towards the right atrium. And so you have your IVC, you have your M mode line set up here. This is what it looks like on the fancier ultrasound machines, not the ones that you guys are accustomed to using. But you have your M mode set up here and it's perpendicular to the IVC. And then you look at the changes in the diameter over time. And you can see there's some collapsibility, right? You can actually measure it. So you can measure the minimum diameter and the maximum diameter. And you really, for us to say in a non-passively ventilated patient, I think if it's greater than 50% collapsible or more, then that patient would benefit from volume resuscitation. And I think this probably, we didn't actually add the measurements here, but I think the minimum is around 1. The maximum is probably maybe around like 1.5. So it's not 50% collapsible, but somewhat collapsible. Questions about IVC measurements? It's probably one of the more common advanced echo uses we use in the critical care pulmonary setting. So I wanted to talk about hypovolemic shock, and it's a little bit different than distributive shock in that, it's usually from volume loss from some etiology, whether it's hemorrhagic causes, right? So trauma, you can have a patient with a GI bleed, or extraperitoneal hemorrhage, and non-hemorrhagic causes. So any patient with severe dehydration, vomiting, diarrhea, they've had external fluid losses. And so classically, this is evaluated, especially in the ED setting, using the FAST exam. And FAST stands for Focused Assessment with Sonography and Trauma. And really the 4 key areas to examine, all assess for free fluid accumulation. So you're looking in the Morrison's pouch, which is the hepatorenal recess, and then you also want, which is on the right. And then you also want to look at the perisplenic space, which is on the left. You look at the pericardial space to evaluate for any effusion, especially if there's been blunt trauma to the thorax. And then you lastly look in the pelvis and specifically around the bladder, just to look if there's any pelvic or bladder injury. And then there's something called the extended FAST exam, which is the EFAST exam. And the only thing that's added to that would be a bilateral anterior lung ultrasound. And that's just to mainly look for a pneumothorax. And this is something that you could do very quickly. And if you're worried about a patient who came in unresponsive, was found down outside, you're not sure if there was trauma sustained, it's something you can look at very quickly to decide on your next move. And so this is just showing what the EFAST exam looks like. So you have your cardiac views, you have your view of the right upper quadrant or Morrison's pouch hepatorenal recess area. You have your view of your spinal renal recess area. You have your view of the bladder. And then you have your bilateral anterior lung view. So this is just showing some abnormal lung findings, abnormal findings. So what are we seeing in this clip here? Yeah, perfect. So there's definitely fluid in the hepatorenal recess, right? So you have your kidney down here, and then you have your liver up here, And then you can see this rim of black. And so that's free fluid. And, you know, they've done studies. If you see the presence of free fluid, even in this little area, it might look like a little. This could mean that there's already a liter of blood in the intraperitoneal space. So this is already something that needs to be evaluated quickly. Well, what else do we see in this patient? Is there anything else abnormal that you guys notice? For the kidneys, you know, under normal, we'll have, you know, the renal pelvis will look a little bit brighter. The borders here, something maybe is a little strange here, but the only other thing I would say to point out would be that there's a pleural effusion as well. You see above the diaphragm, the diaphragm here, and then there's more black fluid here. So there's at least a small pleural effusion. We'd have to scan upward to see how big the effusion is. And then on this clip here, right? So now we're looking at the other side of the abdomen, the left side. And you can see this is the spleen. And again, the spleen is in most patients smaller than the liver. And you can see there's some black fluid above the spleen. You can see the diaphragm here. And then this is, you know, the lung sliding over the diaphragm. This would be the curtain sign. This is just looking at the view of the bladder, okay? So then here it would be a bladder right here, and you can tell that it's bladder and not just regular free ascites because the bladder has very thick walls, right? So there's thick walls that are separating it, and it will look sometimes looks square, sometimes looks trapezoid, depends on how descended the bladder is. I guess in this case, it almost looks triangular, but kind of trapezoid-esque. And what you can see is that there's a little bit of fluid outside the bladder, right? That's not part of the intestine. And so this would be an example of free fluid in the pelvic region as well. It's a small amount, but it's something that's worth noting. Whereas this is something that's much more prominent. And this on the right would look a little bit more concerning for blood because it has a little bit of layering. You can see the bladder here, and then the bladder gives way to just free pelvic fluid. Okay, and so the last type of shock we haven't talked about yet is going to be essentially what you'll see in the CCU, and that's cardiogenic shock. Obviously, even cardiogenic shock has a broad set of differentials, right? So you can have obviously a myocardial infarction, you get post-ischemic stunning, you can have a myocarditis, hypertrophic, dilated, non-ischemic cardiomyopathy. Certainly a lot of valvular abnormalities and septal defects can lead to cardiogenic shock over time, and then arrhythmias. And keep in mind, you can also get a septic cardiomyopathy, right? So even patients who present with an underlying infectious process can still develop cardiogenic shock because they'll have stunning of the myocardium from the inflammatory surge of the infection. And I highlighted this view because when I was taught as a resident, like one of my mentors would use this analogy of you go into like a sushi restaurant where there's a conveyor belt that's delivering sushi to the customers, and there's the person in the kitchen is preparing the sushi. And so the way I always thought that we were taught to differentiate septic shock and cardiogenic shock. So with both of those, septic shock and cardiogenic shock, there isn't an issue with necessarily the blood vessels and oxygen itself. So the oxygen would be the sushi, the blood vessels would be the plates. With septic shock, I would say the customers are sick, right? So because they're sick and vomiting up, and the customers represent the tissues and organs of the body, because they're sick, they're not able to take up any of the sushi or any of the oxygen. And so by the time the conveyor belt goes back to the kitchen, there's still a lot of oxygen and plates left that have not been used. And so that's why when sometimes one of your critical care attendings will ask you to get the central venous oxygen saturation to evaluate whether the patient is septic or has cardiogenic shock. That's why in septic shock, classically, the venous oxygen saturation will be high because the tissue is the problem and it's not uptaking the oxygen effectively. Whereas with cardiogenic shock, now the pump or the chef is sick, and so he's making the sushi very slowly. And so the first customers take all the sushi, And there's less and less sushi available as the conveyor belt goes all the way around, because he's sick and he's slow, and the conveyor belt is not moving that quickly. So by the time it gets all the way back to the kitchen, most of the sushi and plates have been utilized. And so that's why with cardiogenic shock, classically, you have a reduction in venous O2 sat, usually around like 30%, because the pump and the pump is working so slowly that the tissues are uptaking the oxygen faster than it can meet the demand. Does that make sense? And then I just want to show you examples again of classic cardiogenic shock. So, this here, I just want to highlight again the parasternal long axis view, right? You have the septal wall, you have the posterior wall of the left ventricle, and then you have the anterior leaflet of the mitral valve. And you can see the mitral valve leaflet is barely moving up. It's not even going halfway towards the septum. So that's definitely abnormal. And then the squeeze is not great. The cavity size is not shrinking. So this is someone who would have a very significantly reduced EF. And in that same patient, what do we think about the IVC? Yep, so very big, non-collapsible. So consistent with cardiogenic shock type picture. And of course, what would you see on lung ultrasound with cardiogenic shock? So you'd see this. So what are we seeing here? Yep, absolutely. So we have our B lines bilaterally. And notice, with pulmonary edema, like I mentioned before, if you're worried about when you see B lines, you always want to pay attention to the pleura. If it's something that's nice and smooth, right, that'll go be more indicative of something like pulmonary edema. Whereas if it's very irregular and nodular looking, lumpy, bumpy is what's been described in the literature, that would be more indicative of an inflammatory or infectious process. So in both of these instances, the pleura looks nice and linear and smooth. And I do just want to briefly talk about Takatsubo Cardiomyopathy. So basically using this lecture to cover everything else that I haven't talked about yet. So with Takatsubo Cardiomyopathy, it's a stress-induced cardiomyopathy. So really what you get most commonly is a transient regional dysfunction of the left ventricle. It mimics myocardial infarction, but doesn't have any angiographic evidence of obstructive coronary artery disease. And so really classically what you'll get is systolic apical ballooning. But you can get other findings too. You can get right ventricular Takatsubo. You can get basilar Takatsubo, where you have sort of reversal, where the basilar aspect is not moving and the apex is. But basically, you have apical ballooning here. And then what does Takatsubo actually mean? Yeah, excellent. So yeah, taco means octopus. So it basically was named, first described in the Japanese literature, and it basically was described as something that looked like the trap that they used to catch octopuses, or octopi, I guess, sorry. I don't know the plural of octopus, but yeah, I think it's octopi. And so this is just highlighting some other examples of Takatsubo, right? So again, you have the apical ballooning where the basilar aspect is moving inward okay, but the apex itself is not moving that much. And then lastly, I just want to finish by talking about critical care ultrasound during cardiac arrest. So that's something that we are more commonly using than we have in the past. But the main caveat I will say with that is that ultrasound should never interfere with high quality chest compressions or defibrillation, right? So, but that being said, why should we perform ultrasound? Because obviously we want to figure out first, does the patient have a pulse, right? So there have been multiple studies. Ultrasound is definitely better at detecting when there's a return of pulse compared to just touch alone. So if we're not sure we feel a pulse, then during the next pulse check, it's a good idea to stick the probe on the femoral artery and evaluate for pulsatility. If the femoral artery is pulsatile, that's usually indicative that there's return of spontaneous circulation. The other thing is to separate true PEA from pseudo PEA, right? So a lot of times when we do the rhythm check, we see movement, we see something on the monitor, but there's no pulse. So is this actual pulseless electrical activity, or is this real electrical activity? And so why do we care? So pseudo PEA, meaning that there is actual cardiac movement, is associated with better outcomes. So if, let's say, during ROSC, you're seeing cardiac standstill during pulse checks, that's actually been associated with poorer outcomes. So if you've been doing CPR for an extended period of time, and really every time you check with ultrasound, you're getting cardiac standstill, that's usually a sign that achieving ROSC will be unlikely, and that it may be time to think about cessation of CPR. It also will help direct intra-arrest and post-arrest management, right? Because there's few things that we can rapidly assess during the arrest. If the patient has tamponade, if the patient has tension pneumothorax, if the patient has massive PE and we're seeing clots in the right ventricle or right atria during pulse checks, right? That might be important, because that might allow us to give TPA, put a chest tube in, do a pericardiocentesis, because those are all potential things that could alleviate the cause and better quickly establish ROSC. So something to think about. Obviously, it's, again, not going to interrupt your CPR, but it's something you can add to make you feel a little bit more comfortable at how you're performing the cardiac arrest and chest compressions and things like that. I was going to run through a few cases, but I think we're basically out of time. So we'll stop there and just see if you guys have any questions for me.